All right, good morning, everyone. It is 10 a.m., so we are going to get started. I just want to say good morning and welcome to the fourth week of the Wellness and Recovery series. I just want to say thank you, everyone who has been joining us for the past few weeks, and we're really excited to have you for these next 2 weeks. And excited for our workshop this morning. So today we're going to be going over the opioid epidemic, medical strategies for treatment with Dr. Katie Cassel. Katie Cassel, would you like to introduce yourself?
Sure. So as you said, my name is Katie Cassel. I've been a physician at United Indian Health Services since 2001 in various capacities. I served as medical director for a number of years. And of course, in my day, I prescribed plenty of opiates when that was all the rage, and was pretty instrumental in helping reverse that change. And then in 2017, I became licensed to prescribe buprenorphine to treat opiate addiction, and we'll be sharing some of that information with you today. Before I get started, though, I'll turn it back over to Mahia for a little housekeeping.
Wonderful. Thank you so much. We're so excited to have you today. So like she said, the opioid epidemic, medical strategies for treatment. And we just want to remind everyone who is joining that we are live on Facebook and we are on the Zoom. So those who are on the Zoom and joining us, please remember to keep yourself muted, video off. If you have any questions, you can raise your hand or type it into the chat. For those watching on Facebook Live, we have people monitoring. So you're totally welcome to leave questions in the chat on Facebook Live. And there is about a 45-second delay. So if you're leaving a question, it might take us a second to get it answered or bring it up. So please just keep that in mind. There's a little bit of a delay. But again, thank you to everyone joining us, no matter what your platform is. So we always want to go over our group agreements before we get started. We want to remind everyone respect and kindness are key. If you're not being respectful and it becomes a persistent issue, you will be removed. Please show tolerance and sensitivity for differences. Participants in the group come from different cultural, racial, gender, and sexually oriented backgrounds. So please be aware and sensitive to judgmental comments. Use positive language and definitely stay away from using racial, homophobic, and degrading remarks. This is a safe space and it is free of judgment. And so it's all right to disagree with someone else's point of view. However, we don't put each other down for it. This is a space where participants should feel comfortable to be themselves, share thoughts and ideas without any worry of punishment or judgment. If you are sharing stories, if the participants are sharing personal information, they should leave specific names out of their stories or comments, and they can say, I know someone who, for example, but using names often aids in the spread of rumors and detracts from the point of view of, or the point of information trying to be communicated. And of course, if you don't understand something, ask for clarification. You don't be afraid to ask questions. The questions are open in the chat on Facebook Live and in the Zoom. So remember, you're totally welcome to ask questions if you don't understand the information. Don't be afraid to ask questions. The questions. Yes.
The video is a little blurry. I'm sorry on Facebook. I don't know what's going on. You might want to check the settings real quick. Sorry.
Okay. Well, we also want to make sure that people are aware that some of the stuff we might be talking about today might bring up some feelings or concerns. And if you need someone to talk to in this case, please reach out to some of the helplines if you need. We have the mental health hotline for Del Norte here, as well as the 24-hour crisis services that are available. As far as informed consent and privacy, each person's participation in this presentation is voluntary, so please respect the privacy of others and do not share personal information with anyone else. This training is being recorded and may be live on social media. If you are participating via Zoom, please turn your video camera off and stay muted. And as always, we wish to acknowledge the lands that we are meeting across today. I personally am meeting from Talowa Dene lands, but we want to recognize the many lands that people may be watching from, such as the Talowa, Dene, Yurok, Karuk, Hupa, Wiyot, and many rancherias such as Elk Valley, Resagini, Big Lagoon, Trinidad, Blue Lake, Table Bluff, and Bronerville. If you aren't watching from any of those listed, try and acknowledge the land that you are on and recognize where you're watching from, because it's always important to have that information and know that and recognize it. We honor the indigenous peoples who lived together and cared for this land and each other since time immemorial. We honor with gratitude the land itself and the people who have been the stewards of this land for generations. We know the effects of colonization have impacted indigenous people disproportionately, and we hope that through this series we can learn together to help heal and work towards a healthy future. All right, so I am going to just say thank you to everyone who's joining today. And yeah, we're really excited to have Dr. Cassel here today, and I'm going to pass it over to her.
Okay, and then I'm just gonna share my screen and get the presentation started.
Perfect.
Good. Okay, so we're going to move forward with the presentation on the opioid epidemic and what we're doing about it from a medical perspective. So what I'm going to review today is just basics of what is an opioid, how did the epidemic happen, why are we here, how big this problem is, what we're doing to get out of this mess, and what progress we've made so far. So first I'm going to start with what's an opioid and why are they so addictive. So an opioid is got its name from opium, which is a derivative of the poppy plant. And this derivative, opium, has been used for thousands of years medicinally, and it's been used for reduction in pain and to help people sleep. But for thousands of years, it's also been known that opium is highly addictive and can be deadly. So over the years, medications have been developed with the hope of creating a substance that can help with pain and or sleep, but not have the addictive or deadly qualities. And a lot of these medications are ones that people will be familiar with. So morphine was developed in the early 1800s. Codeine came a little later, followed by heroin in the late 1800s. Methadone was made in the mid-1900s. And in 1984, hydrocodone, though it was identified first in Germany about 30 years before, first became produced in the United States under the brand name Vicodin. And oxycodone has a similar history. It was developed in Germany in the 1950s, but in 1995, it began to be produced in the United States in a different formulation called OxyContin, which people have probably heard of. Now, it seems that following just about every new medication that was developed to improve opioids' ability to fight pain without addiction, we've had an epidemic. So in the mid-1800s, the epidemic seemed to begin when Civil War soldiers became addicted to morphine after being treated for the pain related to injuries of battle. And then in the late 1800s, early 1900s, after heroin was developed and marketed over the counter as bare heroin, there was a large epidemic that was considered a housewife epidemic, as there was a large number of middle-aged women that were involved in the addiction at the time. And then in the mid-1900s, Vietnam War soldiers were exposed to heroin in the war, and then it became more readily available in the United States. At the time, this was more of what was considered an urban epidemic, which will contrast with the current epidemic that we're seeing now. So why are opiates so addictive? And a lot of this has to do with a hormone in the brain called dopamine. Dopamine is a hormone that's released in the brain when we have an experience that's pleasurable or rewarding. So the typical examples of this are when people eat or have sex, that this dopamine surges and gives us that sense of reward in the brain. And opiates, as well as almost every other addictive substance, increase that dopamine level in the brain and gives us that reward. And of course, opiates have another kind of insidious side to them, is that when people stop opiates, they experience withdrawal. And during that withdrawal, they feel very sick. They feel pain all over. They are nauseous, they throw up, they have diarrhea. In addition, their dopamine levels really drop, so they just feel, unloved and horrible. So it's a very difficult addiction to get through when you're trying to recover. Now, looking at dopamine levels in the brain with certain activities, I wanted to contrast kind of these natural rewards with ones related to substances. So in this graph here, you see what's called a basal output of dopamine in the brain, and this is mice studies. And 100, that you'll see 100 on these graphs, and that just means a baseline amount of dopamine. So what the amount of dopamine that's available just at rest. And then you can see when there's food introduced that dopamine level increases about 50%. And then with sex, it increases about 100%. So it goes up to 200. Now, if you contrast that with substances of abuse, and down here in the lower right corner, you'll see morphine and similar basal rates. So you go from 100 up to 200 with morphine, and then it lasts for several hours. Similar with nicotine, but it only lasts a short period of time. And in the upper right-hand corner, you'll see cocaine, and that gives you about a 3-fold increase in dopamine levels lasting a few hours. And then looking at the upper left corner, you'll see amphetamines, which give you about a 10-fold increase in the amount of dopamine that's in the brain, which can help explain why this is really such a highly addictive drug as well. All right, so when it comes to the opioid epidemic, the current opioid crisis, how did we get here? And a big piece of this is definitely opioid overprescribing, which really began in the 1990s. Prior to this time, or at least in the 20 years prior, opioids were used very, very cautiously for pain. They were used much more to treat pain at the end of life, and they were used in low doses for chronic pain. But as I stated earlier, there were these drug companies that started to develop opioids in the late 80s and 90s, and they wanted a market for that. So those drug companies did some studies on chronic pain, and they were short studies. They were 20 to 24 weeks long, but those drug company sponsored studies did show that these medications improve people's perception of pain. The other thing that happened around this time is that there were some high-profile lawsuits related to the undertreatment of pain. In general, these lawsuits were end-of-life pain, so they were a little bit different, but a lot of the discussions started to get people in the medical community concerned that with this research coming out that we were really undertreating chronic pain. And then partially because of drug company pressure, there was legislation that happened around making sure that physicians had specific training for chronic pain management. And in California, all physicians had to go through a 12-hour chronic pain management training continuing education seminar. And the messages that we received at that time were that opiates really were safe and effective for chronic pain, and that as a rule, physicians were undertreating pain with opiates. And that we really didn't need to worry about high doses of opiates. They were really considered quite safe when prescribed in an appropriate way. and that they didn't really see addiction with chronic pain. Less than 1% of people in the studies were found to develop addiction to opiates. And then what happened as somewhat as a result of this was something that you might have heard of called pill mills. And pill mills were, and still are, practices where a physician will set up a clinic designed for a pain management clinic, but really all they do is prescribe high-dose opiates in large quantities. Oftentimes, these are cash-only clinics where patients have very short visits, very little physical exam, and almost no treatment other than the opiate prescriptions. And so what we saw over the course of just a little over 2 decades is the number of prescriptions written for opiate medications went from a little over 70 million to over 200 million. So a 3-fold increase in the number of written prescriptions. What this doesn't take into account is the strength of those prescriptions. So the strength of the prescriptions between 1992 and 2012 went up about 600%. Now, at the same time, we were starting to see an increase in non-prescribed opiates, so heroin being the most common of those, at least initially. And during this same time that prescription opiates were on the increase, the price of heroin was dropping and the availability of heroin was increasing. And we did start to see information that people who started on heroin first got their kind of taste for it from using prescription opiates and abusing prescription opiates. But many people who start as only a small percentage of people who start abusing prescription opiates would switch to heroin. But those who use heroin, many of them tried the prescription opiates first. That does seem to be changing. And in more recent data from 2017, about 1/3 of heroin users started straight with heroin without going through a prescription opiate first. Now, the other thing that I'm going to talk more about in a minute is that fentanyl, which is a synthetic opiate that's very potent, came onto the market and really increased availability in about 2014, 2015. And so this is just a little information on the price of heroin over the years. And this is based on a pure gram of heroin, not necessarily what people are buying as a gram on the street, but dramatic decrease in price over the last 30 years. All right, so how bad is the opioid epidemic is the next thing I'm going to cover. And what we saw is over the 20 years of increase in opiate sales, we saw opiate deaths just tracking right along with it. And between 2000 and 2012, there were estimated to be about 500,000 people who died from opioid overdose deaths. And then in looking at heroin use and just the number of users in the thousands over this same period of time, we see that there's, in 2014, there were about 1 million known heroin users in the United States, and we know that that has increased since 2014. And then in looking at deaths related to opioids and other drugs, those are covered in national data in poisonings. And over the course of the first part of this millennium, the poisoning deaths quickly surpassed deaths from many chronic diseases. And in 2014, the number of overdose deaths even surpassed the number of deaths from motor vehicle accidents. And then we had fentanyl come on the scene, and that really changed things even from that somewhat dire point in 2014. Now, fentanyl is a synthetic opiate that's manufactured. It doesn't require the raw material of opium. And so it can be made in the United States fairly easily. It's cheap to make, and it's incredibly potent. So it is 50 to 100 times more potent than heroin. And what we began to see in around 2014, 2015 was fentanyl being added to heroin, as well as other drugs being sold. And because it is so much more potent, it's also so much more deadly. And we started to see a big increase in deaths related to fentanyl contamination, you might say, intentional contamination of heroin with fentanyl. And so looking at data, the last chart I showed was stopped around 2014, 2015, and that was right as the fentanyl crisis began. And you can see that the deaths related to opioids really took off at that time, and the majority of that increase was related to fentanyl. As we can see, the heroin deaths and the prescription opioid deaths seem to be leveling off. Now, in looking at this problem in the United States, the areas that are in blue are areas where there are fewer overdose deaths. And as you get into the brighter and red colors, those are the areas where the overdose deaths are higher. And it's not absolutely a rule, but one of the trends that we see is that these bright red areas are areas that are a little bit more rural. So it has hit rural America a little higher than the bigger cities. And then looking a little bit more closely to just Humboldt County and Del Norte County and comparing that to California, this graph here is looking at 2002, and even as far back as 2002, which for many places was the start of the epidemic, Humboldt County had a large number of overdose deaths. And this was shortly after I came to United Indian Health Services, and I remember a study coming out from US News and World Report that same year that looked at the number of prescriptions per capita at every county in the United States. And Humboldt County was the second highest prescribing county per capita in the United States. So we've had a prescribing drug issue in Humboldt County for longer than many others. But if you look at this next slide, you can see that most other counties in California caught up with Humboldt County, Del Norte as well. All right, so we know we have a problem, and we know it's a big problem, but how do we get out of here? I'm going to talk about a couple of strategies. A big one is preventing new addiction. Another is preventing overdose. And last, I'll talk about helping people recover. So with regard to preventing new addiction, I'm going to talk mostly about the stopping of overprescribing opiates. There is a lot of exciting work that's going on in terms of early intervention and childhood education. That's not really my expertise, but it is very exciting work that is really starting to help. But in terms of overprescribing opiates, a lot of the change has come from the realities of what we have seen in using opiates to manage chronic pain. And over these last 20, 30 years, we have seen that when you look at chronic pain treated with opiates versus chronic pain treated with non-opiate medications over time, people who are treated with the chronic opiates don't do as well. They have more health problems, more risks, and overall the evaluation of the pain management is actually worse. So we're no longer using opiates as our main strategy in managing chronic pain. We've also learned that about 1/3 of people who we start on chronic opiates will develop addiction. That's of course much higher than the 1% that was originally proclaimed. And we've learned that so many people have unintentional overdoses on the prescribed opiates, even when they're not prescribed at very high doses and people are just taking them to help with pain. As well, we've learned that medications are diverted. So people are very generous with their medications and will give them to others that are in pain. So these medications are shared, and this can lead to a really dangerous situation. And sometimes medications are diverted without the person who's been prescribed them, without their knowledge. So children will get into them from medication cabinets, or teenagers will use them to experiment. So we're really moving away from opiates for chronic pain. Now, how this is happening is a kind of a crackdown in many areas. One of the biggest changes is that all states are now mandated to have online monitoring of every opiate prescription that's written. And so these systems can then allow drug enforcement agencies to see prescribers that might be fitting into more of those pill mill type operations, so that they can be addressed appropriately. Additionally, now that there are these systems in place for monitoring, physicians, whenever they're prescribing, can go in and look up a patient and make sure that that patient isn't getting prescriptions from other physicians, so that we're really more aware of the safety of prescribing that we're doing currently. Looking at those databases is now mandated in California. Before any prescription is written, a physician has to go in and look at that database, and then if they're continuing to do refills, they have to look at it every 3 months. Additionally, there's been guidelines that have been distributed by the Centers for Disease Control and Partnership Health Plan about how to manage opiates and what are appropriate kind of thresholds for prescribing. And if physicians are prescribing outside of these guidelines, the insurers are starting to deny coverage for those medications. And then more recently, we have seen some cases of criminalization where physicians who have overprescribed opiates without using appropriate precautions have actually served jail time for the deaths of their patients. Now, current opiate prescribing guidelines are to limit opiates to really just a very short period of time, if at all, after a serious injury, and to really rely on non-opiate prescriptions whenever possible. It's advised to not start new patients on opiates for chronic pain, and to not mix them with a category of medications called benzodiazepines, which are typically used for sleep or anxiety, because that combination tends to suppress the drive to breathe even more, so it's a dangerous mix. When people have been on chronic opiates, the goal is to try to taper, so to slowly reduce the amount that people are on, and to try to discontinue the medication whenever possible. We're advised to avoid high-dose opiates, and to offer a medication called Narcan, which can block opiates in the case of a overdose. And I'll talk a little bit more about that in a minute. All right, so I want to switch over to preventing overdose. And the main way that we do that is with a medication called Naloxone, which is an opiate blocker. It's a medication that when somebody enters an overdose, this can be provided to them early in the overdose, and it blocks the opiate so that people start to breathe again. A brand name of Naloxone that people have probably heard of is called Narcan, and it's available in 2 different delivery packages, you might say. It's available in an injectable form, and this here is an example of on the left of one of the automated injectors that when you use it, you pull off a cap and it talks you through providing this to another individual. And then the other formulation is a nasal spray. And this one on the right is one of those nasal spray devices. There are various devices for each of these, but it's injectable or nasal are the 2 methods that are out there in the community. There's a big push right now to get more Narcan, more Naloxone out into the community. And there's a lot of distribution programs that are making sure that it's available not only to people who are using opiates, but just to general households. The more people who have availability of Naloxone, the safer we are from opioid overdose. Additionally, with the new guidelines that are out, anybody who we prescribe an opiate for, the recommendation is to offer and prescribe Naloxone with each prescription. Now, how naloxone works is in an overdose, you have opioids that are attached to receptors for opioids in the brain. And it's when these opioids are attached that it provides that stimulus that slows down breathing. And if it's too much of that, people can actually stop breathing. So when people are given, when a person in overdose is given naloxone, naloxone is very, very attracted to these opioid receptors. So it actually bumps off the opioid from the receptor and it binds tightly so that this opiate can't reattach and cause the person to go into overdose again. The naloxone does dissipate in the system, but it takes 30 to 90 minutes for that to happen. So as long as that opiate is also being eliminated from the system in that 30 to 90 minutes, that person should be okay from overdose. But sometimes they're on an opiate that's either at a very high dose or is one that lasts longer than the Narcan. So it's important to, whenever Narcan is given, to also call 911 in case as the Narcan wears off, that opioid is still active and can cause the person to go back into overdose. Now, the other thing that is becoming more readily available is fentanyl test kits to allow people to avoid taking fentanyl in. And what you do with these test strips is you take them to test usually the residue of whatever drug you've purchased to use. And if only one line shows up on the test strips, it means that there's fentanyl in the drug that was purchased. So that person then has some choices to make. They can either not use it at all, they can use quite a bit less, they can make sure that there's somebody there with them when they use it, and that they have something to reverse an overdose in case that were to happen. And if there's 2 lines in it, there's no fentanyl. So at least from a fentanyl perspective, that substance is safer. All right, so next I'm going to talk about things that we're doing medically to help people recover. And I want to just briefly talk about treatment and standard treatments for opioid addiction. And these really are the mainstay of treatment. And medications are added to that to assist, but they don't replace the fact that treatment, these behavioral supportive treatments are really key to overcome addiction. So those include detox, residential treatment, intensive outpatient treatment, Narcotics Anonymous, Red Road, and many more modalities. I know that there's going to be a talk later today on these behavioral treatments for addiction, and I'll let the folks that do these sorts of things all the time take you through that. Now, in addition to the treatment, there are medications that we can use to help people prevent relapse. And those medications are methadone, buprenorphine, which goes by a few brand names, suboxone and Subutex are ones people have often heard. And then there's Naltrexone, which a common brand name of that is Vivitrol. Now, the way these medications work is again at that opioid receptor. And I like to explain this in terms of thinking as the brain as your car, and that opioid receptor is your ignition. And then the opioid is kind of a key that goes into that ignition and revs that up to give that response to the brain. Now, methadone is a key that fits into that ignition. And when you turn it on, it's what we call a full antagonist. It generates a full effect. So when you press on the gas, that car can go its maximum speed. That makes it potentially somewhat dangerous. So methadone has to be very highly monitored for it to be safe. Now, buprenorphine is another medicine that we use for medication-assisted treatment. That key fits into the ignition switch, and you can you can turn it on, but it has a limiter. It only generates a limited effect. So when you have buprenorphine in that receptor, it will only give you about half of the half of the oomph. It's not nearly as activating. It's also not nearly as dangerous, much less likely to have overdoses related to buprenorphine. It's not impossible, but it's pretty difficult. And then the last medication is something called Naltrexone, and it acts less like a key that can turn on an engine. It acts more like a cap over that ignition switch so that no other keys can fit in it. There's nothing that's going to get that engine to start. So it's really a blocker. And the way that these work is partially, well, I should say that buprenorphine and methadone, they work in that you usually give people an amount of medication so that they don't feel high, but they don't go through withdrawal. And because these keys fit fairly tightly in that ignition, if somebody were to use heroin or another opiate, it's not going to bump these off to attach to the receptor. So in general, when I have people who have a lapse and try using heroin when they're on buprenorphine, I ask them, well, how was it? They're like, it didn't really do anything. And that's part of how these work, is that if somebody tries to use heroin on them, they just don't do very much. So it stops that reinforcing behavior. Now, naltrexone doesn't help people with that feeling like they're not having cravings, because it doesn't have any opioid type effect. It really is just a blocker. So it just prevents heroin, if they take it, from having an effect. And then this is just a slide to kind of give you a different sense of that kind of gas pedal effect that I talked about. So when you have methadone, it's a full agonist. It will give you 100% of the potency of opioids. So people can overdose on methadone, and it has to be very closely monitored. Whereas buprenorphine, you give high doses, you're only going to get to that 40, 50 miles an hour. So it's not nearly as dangerous of a medication for people to have. As a result, we can give people a week's worth of the medication at a time without feeling too concerned about overdose. And then naloxone, again, it's a blocker. It's not going, that person's not going to get anywhere in terms of an opiate effect from the naloxone. Now, how effective are these things in helping us with addiction? We do know that using MAT does reduce overdose deaths. And this is a study from a community where they looked at the number of heroin overdose deaths, and you can see that in red. And you can see that going down as the number of people who are prescribed methadone and people who are prescribed buprenorphine in the community increases. This is another study looking at a very specific group in Massachusetts, where they were comparing people who were receiving non-medication assisted treatment versus people who were receiving medication assisted treatment with either buprenorphine or methadone, and the number of relapses that were experienced per month of people being in the program. And you can see that it is that the reduction in relapse, at least in this study, was pretty significant and worth noting. Now, comparisons looking at buprenorphine versus naloxone, so that's a brand name suboxone and Vivitrol. I have to say, this is, compared to the Massachusetts study, this is a little bit more of what I have seen in practice, is that of the people who walk through the door, about half of people make it through the first month without relapsing. It's even with medication-assisted treatment, it's hard to overcome that hurdle. And it's a little bit harder with the Vivitrol, the naloxone, because people do have to be through withdrawal before they can get the first treatment with Vivitrol, the first treatment with naloxone. Otherwise, it will stimulate withdrawal symptoms. Okay, I'm going to go into a little bit of detail about each of these medications, starting with methadone treatment. Now, methadone is, its use in addiction treatment is highly regulated by the DEA. Somebody with addiction can't just walk into any clinic and get a prescription for it. They have to receive the medication from a clinic that is federally certified to do so. And the way that medications are given at a methadone treatment clinic is that the patient comes in every day, and they have a urine drug test, and then a nurse meets with them, hands them the methadone that they're going to take for the day. It's generally in a liquid form. The client is observed to drink that dose, and then they come back the following morning. There is counseling and those sorts of things integrated into it as well. Until just last week, we did not have a methadone treatment clinic in Humboldt or Del Norte counties, but the first clinic did open up last week, and that's Aegis, and it's a clinic in Eureka, and they are accepting patients for methadone treatment. Now, buprenorphine is a medication that has been much more widely available in Humboldt and Del Norte counties. Some of the formulations that are available is a combination medication, which has buprenorphine and naloxone in it. The common brand names of this are suboxone and Zubsolv. This medication comes either as a tablet or a strip. Both are taken by mouth, placed under the tongue until they dissolve, and they're given once daily. Now, the combination has a very specific purpose. The buprenorphine alone is effective for preventing or for treating heroin addiction. The naloxone is there to prevent the medication from being dissolved and injected. So naloxone is Narcan. And naloxone, if you put it under the tongue, doesn't really absorb well. So when people take suboxone as prescribed under the tongue, the naloxone doesn't really do anything. But if somebody were to take one of those tablets or strips and try to cook it and inject it, they would get an effect like Narcan. So they would go through an immediate withdrawal and feel pretty crummy. So it's really there to prevent injection use of the suboxone. Now, there is a formulation that is just buprenorphine alone without the naloxone, and it's called Subutex. We try to use that less often than the suboxone, because we really would prefer to have it not be injected. But sometimes we do use Subutex, particularly for pregnant women. So Subutex is available as a tablet, taken again under the tongue once a day. But there are also some other formulations of buprenorphine. There's an injectable form of buprenorphine, which is given once a month and will stay in the system for a number of weeks after injection. And then there's an implant, which is implanted in the arm and is changed out every 6 months. I haven't really seen that used very often, but the injectable is starting to get more use. Buprenorphine, unlike suboxone, does not require any special certification of a clinic, but the prescriber must have a special waiver to their DEA license. It's sometimes called a data waiver or an X license. And all it means is that prescriber has gone through the special training to be able to safely prescribe buprenorphine. They've been tested and had that qualification certified by the DEA so that they can prescribe. Now, one of the challenges with buprenorphine is that people do have to be in a certain amount of withdrawal before they start taking buprenorphine. Otherwise, it actually makes them feel worse because it isn't as potent as heroin in terms of an opiate effect. So you have to wait till people are feeling crummy, and then when you give it to them, it makes them feel a little bit better. Now, the typical process for people getting started on buprenorphine is that they'll come into a clinic for a scheduled intake visit, and they meet with a nurse and or provider, and they have a history that's taken and a physical exams done. They sometimes have lab tests performed, and then based on the provider's assessment, they might receive medications that day and with instructions for how to start buprenorphine at home, or they might come back to have a visit where their first dose of the buprenorphine is done in an observed way. After that, they enter what's called stabilization. So the patient will usually have visits every week with a provider. At that time, they're really working on becoming sober and just entering into recovery work. And then once they're on a stable dose and they've been sober for a number of months, they enter what we call maintenance. During maintenance, people will come into the clinic, usually starting every 2 weeks, but it can be stretched out to every 4, and people have been in maintenance for a long time. Sometimes that can even be every 3 months. And typically it will match how they're doing in their recovery. So as people are getting back to more productive living situation, working or going to school, meeting their obligations, that's when we stretch things out. Now, in general, when people start on buprenorphine, I encourage them to think of it as a 1-year minimum of treatment before they consider stopping the medication. There is no maximum. People can stay on buprenorphine for years and years if that's what they need to maintain their sobriety. And part of the reason why we recommend that is that when people discontinue within that first year, the relapse rates are really quite high. So 50% relapse rate within a month of discontinuation when people are early in recovery is not uncommon. And in one study on, again, early discontinuation, about 80–90% of people had relapsed within the course of a year after discontinuation. So ideally, you'll have somebody on maintenance with buprenorphine until their lives are really very, very solid. They're no longer interacting with people that they used to use with as much as possible, and they feel like they're really ready for a slow and gradual withdrawal so that we prevent withdrawal symptoms while they're discontinuing the medication. All right, the last one I'll talk about is Naltrexone, and that's the blocker. It can be taken as a tablet, which is taken daily, but it only lasts in the system for about 2 days, so it's not terribly effective at preventing opioid use when given in tablet form because it's out of the body so quickly. There's been more success with the injectable form, which is called Vivitrol, and that lasts about 4 weeks in the system. And that is given monthly in an office setting. It doesn't have to, you don't have to have any special license to be able to prescribe Vivitrol. And the one challenge is that people have to be completely through withdrawal before they can get their first injection of Vivitrol. So at least 7 days from a short-acting opiate like heroin. All right, so the last question is, are we making progress with all this work over the last decade or so? And some evidence is saying yes. So in 2018, it was the first time in 20 years where the trend was not going up in terms of number of deaths. So it was the first time that overdose deaths dropped in decades, which was encouraging, but still a long way to go when you see how many overdoses per year, going from 70,000 to just under 70,000 still seems like quite a lot, looking at where we started in 1999 with under 20,000 deaths. Also encouraging is looking at high school data and drug use among high school seniors. So in 2019, the percentage of high school seniors that reported using prescription opioids recreationally was its lowest in 30 years. And they had similar data regarding heroin in high school seniors, and it was the lowest that it had been in over 40 years. And then looking at prescribing rates, when you look at particularly Humboldt and Del Norte County in 2016, you can see that we were in the very high category of prescribing opioids. And in 2018, those rates have dropped significantly in both counties, still quite a bit higher than the rest of California on average, but heading in the right direction. And then this is data from opioid overdose deaths and the causes of them in Humboldt County. I don't have similar data for Del Norte County. And because this data here is looking at all overdose deaths, and just some of them are opiates. In the graph below, I put the total number that involved opiates, and you can see that in 2018 with 14 deaths, this was the lowest number of overdose deaths related to opioids in quite a long time. So though we have some reasons to feel encouraged, we've started to get data back nationally from 2019, and it looks like that little dip that we saw is starting to come back up. And we are receiving some information that overdose deaths since the COVID pandemic has begun, that overdose are increasing. So obviously more work is needed, and more work is needed somewhat urgently. All right, and that is the end of my presentation on medical strategies for treatment of the opioid epidemic, and I'm suspecting there may be some questions.
Wonderful. Thank you so much, Dr. Cassel. That was a very informative presentation. And I swear every time I watch these presentations, I learn something new, even though they all kind of cover similar stuff. It's like, it's so great to get different perspectives. So I just want to say thank you. We do have a question from someone in the Facebook Live chat. And they asked, is naloxone prescribed with Zyprexa? And how do you treat meth voices brought on by drug psychosis?
Naltrexone is generally not prescribed with Zyprexa because it wouldn't block opioid, because it only blocks opioids. It doesn't block anything related to Zyprexa. And treatment of auditory hallucinations in areas of abuse, the first treatment has to be to get people off of the substance, because it's really very difficult to fight the substance in what it's doing. So the first strategy is to get people through addiction treatment and then see where you're at. So people who are having that type of difficulty with substances, I'll often recommend that they go through a detox program that has psychiatry there. So a place like Waterfront in Eureka, where somebody can both go through detox off of the medication and see a psychiatrist while they're there to manage medications, because each person is going to be a little bit different.
Wonderful, thank you. And I just want to, I put it in the chat, but I want to open it up. If anybody has any questions, you're welcome to put them in the chat and we will read them off for you. And yeah, anybody on Facebook Live, you're allowed to leave questions. We do want to remind you though that there is a little bit of a delay. So maybe for now, Dr. Cassel, if you have any last words or maybe your own personal advice for people watching.
Gosh, I think I said a lot already, but just the one thing that I've come to see over time is that with heroin in particular, I have seen that people are much more successful with recovery and transitioning to a medication-assisted treatment if they go through a fairly intensive recovery process. Which is not to say that I haven't seen people be successful without going through detox and residential treatment. But I have seen, it seems that people are much more successful when they have the support of a community and a program to really do the mental work of recovery from substance use rather than just medications. Medications alone, they help, but they're not really what gets people on track in the long run.
Wonderful, thank you. So we do have a couple more questions coming in. Someone in the Facebook chat asked, how long do you recommend patients to be on this treatment?
As I mentioned, the treatment with medications is something that we recommend, or I recommend a minimum of a year for people starting on buprenorphine. And the rationale is that people have a high risk for relapse if they stop medication early in treatment. A lot of times people will get off of heroin and a few months later they're feeling like their lives are already really turned around and they want to get off of the medication. But oftentimes they're not really quite ready. A year in recovery is still early. And so I encourage people to wait a minimum of a year so that they can go through all of the stressors that a year brings into their lives, and they can be sure that they're really, really centered and ready to gradually get off of the medication. So it just adds a little level of insurance for them, that it'll help them if they have relapse.
Wonderful. And then another question, can we get a list of detox clinics that are in California?
You know, I don't have a list of detox clinics in California. Generally, when I have somebody who needs detox and for some reason waterfront isn't available to them, I will refer them on to our substance abuse counselors. So that may be something that our substance abuse team has a little bit more information on and could share.
Awesome. And then there was another question. Is there any way this PowerPoint can be shared with participants via email?
I know I sent a copy of the PowerPoint presentation to you, and if there's a way for people to, I don't know if there's a way to post it or for you to send it, but I'm happy to have it shared wherever makes the most sense for people.
Awesome, thank you. Yeah, we can definitely share that out since you're comfortable with it. And for those watching, if you register for our Eventbrite, we can upload it there for you to have access to. So make sure that you're registered for Eventbrite, and we'll make sure to go over that information before we leave today. We did get another question in the chat. Are you aware of the length of time on average that it takes for a client to re-engage in treatment once they relapse?
That's something that's probably as variable as the number of people that are that are having difficulties with addiction. So it's really independent. But in general, once people understand how to access care, so they know kind of how to get into treatment, it makes it a little easier for the next time they come in. But how long it takes between when they relapse and when they engage in treatment again is pretty individual.
Wonderful. Thank you so much. And if anyone has any last minute questions for Dr. Cassel before we get off today, we want to open it up. And I just want to again say thank you to Dr. Cassel for joining us today and for your amazing presentation, wonderful visuals, and very explained it so well for me as someone who is still learning always. It's wonderful. Your presentation was wonderful. And yeah, we're just very thankful. We have lots of thank yous in the chat. So yeah, we appreciate you coming on today.
And thanks for having me.
Wonderful. Well, if we don't have any further questions in the chat right now, I'm sure if anyone has any further questions in the future, is there any way that they can get in contact with you, or sources you recommend for them?
I'm trying to think of the best way for them to reach me. I don't know if I put my email address on the slide, but I would say with a call through to UIHS would probably be the best way, and with a message. Mm-hmm.
Wonderful. Well, thank you so much again, Dr. Cassel. Yeah, we really appreciate having you today.
And thank you for all your good work. Bye now.
Thank you. Oops. All right, everyone. So before we get off today, as always, we just want to go over some stuff about the Wellness and Recovery series. Again, thank you to our presenter for being on today. Very engaging and informative workshop, and we really appreciated having her today. Again, this is our 4th week of the Wellness and Recovery series. Next week is actually going to be our last week. So we do have a little bit more information before we get into our last week. Again, as always, even though we are halfway through this workshop or the Wellness and Recovery series, you are still able to register through Eventbrite for the remaining events. You can register through the Wellness and Recovery series.eventbrite.com. For the next 2 weeks, we'll still be having live presentations Tuesday, Wednesday, and Thursday until July 30th. This will include speakers, panel series, videos, and activities, along with social media campaigns throughout the rest of the month. We will be on Zoom and Facebook Live, so stay up to date and informed on our Eventbrite page, of course, as well as our Facebook page, which we have for the Wellness and Recovery. So again, as always, we have our Wellness Art Challenge going on for this month. It is going to end on the 27th. That is our deadline, July 27th. It's coming up soon. We haven't gotten many entries, but you're still welcome to join in. Doesn't have to be a masterpiece. We're not judging by art skill. We just ask that you include what your wellness activity is. So you can download the PDF on the Wellness and Recovery Facebook page or on our Eventbrite. If you are registered for Eventbrite or haven't yet, make sure to register, and the PDF will be included on there. All we ask is that you draw in the middle of the basket what your wellness activity is. And you don't have to draw it. You can type it, you can write it, you can write a poem, you can put in a video. Like, the sky is the limit. So yeah, what are some things that you do in order to keep your mind, body, and spirit healthy? If you would like, you may take a picture, or you can scan it in and upload it on social media and use the hashtags #HealthyDelNort and #WellnessChallenge, or you can email it to us at rxsafedelnort@gmail.com. Just make sure to include the artist's name and the age group. So if you are entering on this Wellness Art Challenge, you are entering into a raffle. We do have age groups for the raffle. We have 0 to 5, 5 to 9, 10 to 14, 14 to 24, and 24 up is adults. So again, make sure to do the Wellness Art Challenge for an entry into our wellness raffle with some awesome prizes. We got books, we got toys, we got the grand prize, and yeah, so make sure to enter. Everyone is welcome to join with any entry. And again, like I said, we are nearing the end of the Wellness and Recovery series. It's been wonderful the past month, and we really enjoyed all of you engaging and taking part in this, because it's really important if you are joining in on these workshops. and presentations. So again, we are on the second to last week. This morning we had the presentation with Dr. Cassel, and this afternoon we will have Jeff Guido and Robbie Laura from UIHS from 2 to 4 p.m. And so make sure to tune into that. Information will be on our Facebook at the Wellness and Recovery series, as well as on our Eventbrite. This is just kind of a quick overview of the last 2 weeks, 3 weeks, but we're on the second to last week. So make sure to go over that and see what we're gonna be up to for the last 2 weeks, so you can jump in and join. And again, as always, please fill out our evaluation. I am putting it into the chat right now. And we just want to make sure that everyone fills out our evaluation form because it does give us some information, and each eval form filled out is your entry into our raffle. So we're going to have some great prizes at the end of the series. So make sure you fill out those evals every time you do these workshops and presentations. Anytime you join in, you're welcome to fill it out and get an entry into the raffle. If you want to stay involved, you can check out our Facebook page, the RX Safe Del Norte website, the RX Safe Del Norte Facebook. So again, I just want to say thank you to everyone for joining today. We really appreciated having you all. And remember to register for Eventbrite for the last 2 weeks and fill out those eval forms. And hopefully we'll see you this afternoon for our afternoon presentation. Thank you, everyone. Have a good day.